is one of the most common reasons for physician consultation and has been a long time topic of discussion. In 1995, Dr. James Campbell addressed the American Pain Society, urging healthcare professionals to treat pain as the fifth vital sign, saying if pain were assessed with the same zeal as other vital signs, it would have a much better chance of being treated properly, which the society agreed to and set out with a national campaign. Later, the Veterans Health Administration jumped on the pain train by introducing a national strategy to improve pain. The group suggested that pain be recorded in a way that made it highly visible and facilitated regular review by the healthcare team through the use of pain scales to record and chart pain intensity. However, since then, researchers have not been able to demonstrate improved pain treatment or outcomes from measuring pain as the fifth vital sign. It has even been suggested that the campaign directly contributed to the prescribed opioid epidemic that America has experienced. So, in 2016, the American Pain Society published authoritative guidelines acknowledging that the evidence surrounding the use of these unidimensional pain scores, like the numeric pain rating scale or visual analog scale, is weak. They urge that in addition to these scores, there should be 7 further elements in pain assessment, promoting a pain conversation between patient and clinician. Even today, however, the Centers for Medicare and Medicaid Services requires documentation of a clinical assessment for the presence or absence of pain, using a standardized tool and an accompanying follow-up plan if pain is present. But it is not required that you use the numeric pain rating scale or visual analog scale specifically. As we will talk about, pain is a multifaceted experience with differing physiological mechanisms representing mechanical, cognitive, emotional, and social dimensions. This newer information about pain science may not be getting through to the clinician in an easy-to-integrate format, or the clinician may be ill-equipped to change or even refuse to change their assessment of pain. Physical therapists and other healthcare professionals have traditionally received education using a biomedical approach to pain, using management of physical factors like guarded movement patterns or muscle tension and lifestyle factors like sedentary behavior or deconditioning. Even newly graduated PT students with an increased awareness of these aspects are not using them in practice. The problem is when only structure or pathoanatomy are considered as a cause of pain, problems arise in determining diagnosis, staging, deciding treatment, and predicting outcomes. This can lead to an overutilization of resources, inaccurate diagnosis, ineffective interventions, and poor patient outcomes. Clinical integration and decision-making skills about pain first require the clinician to be able to identify the pain and its source. Using recent developments in pain-related sciences, clinicians can get a powerful feel for prognosis and awareness of new therapies and render some currently used tools and tests obsolete. So let us start with defining pain itself. In 2020, the International Association for the Study of Pain updated their 1979 definition of pain to an unpleasant sensory and emotional experience associated or resembling that associated with actual or potential tissue damage. This definition proposes that inputs such as anxiety, fear, and frustration affect the same neurons in the CNS to create a perceptual experience, the same as from damaged tissues. These other factors powerfully influence the central processing of incoming information from damaged tissues as well. Pain can be divided into acute adaptive and chronic maladaptive. Although pain is usually seen as a negative factor, pain can be advantageous to protect weakened or diseased tissues. Problems occur when all pains and pain behaviors are seen as a result of tissue damage. Pain mechanism classification systems have been introduced into the diagnostic process for practitioners. Based off of the PMCS by Gifford and Butler, there are 5 categories based on mechanisms that include nociceptive, peripheral neurogenic, central sensitization, affect/cognitive, and autonomic motor, which we are going to go through right now. Nociceptive pain primarily relates to acute pain and is the result of mechanical and physiologic processes in injured tissues that stimulate high threshold primary afferent C and A delta fibers. It is associated with injury, inflammation, and repair with a clear stimulus and response relationship. This is usually the easiest of the mechanisms to identify. It primarily is acute, but may present in adaptive chronic pain states where poorly conditioned tissues need protection from potentially damaging movement and forces, or in disease states that maintain abnormal tissue biology, like inflammation. This pain usually improves naturally or in response to treatment like ice, anti-inflammatory and analgesic medications, splinting, and graded recovery of range of motion and strength. However, the pain can often spread after local injury and appear in tissues that were not originally damaged, referred to as secondary hyperalgesia. This concept is an abnormal mechanical sensitivity of tissues that are fundamentally normal, which can cause many false positive results in a physical examination of musculoskeletal and neural tissues. Peripheral neurogenic pain is seen with injuries such as laceration, compression, overstretch, and or the persistent presence of inflammatory fluids creating a neuropathy that can dull impulse transmission or worse, initiate increased impulses from the injury site on the nerve. Peripheral neurogenic pain can be greatly varied with symptoms like deep aching, cramping, burning, stinging pain, or paresthesia that can come in bursts, in time with the noxious stimulus, or persisting for a longer duration with mechanical influence of a nerve. Sometimes the pain can have a mind of its own and come on spontaneously. These symptoms may be common to a cutaneous nerve or a nerve root and present within a specific field on the body. Some patients may have nerve injury like entrachment or compression and never complain of pain at all. A peripheral neuropathy often affects and spreads pain to other parts of the body from the original injury. At a deeper level, the subtly controlled balances of inhibition and excitation with normal sensory processing is affected. Changes in synaptic efficiency, death of inhibitory neurons, and structural reorganization of nerve cells and their connections are known to occur in the dorsal horn after peripheral nerve injury. This can lead to permanent rewiring, allowing normal innocuous impulses from uninjured tissues to excite ascending neural pathways linked to the sensation of pain. Unfortunately, this phenomenon may lead patients to unnecessary surgery or therapy directed at innocent tissues. Central sensitization is pain related to altered central nervous system circuitry and processing. The CNS cells change when subjected to high threshold input. While an upregulation of CNS sensitivity is great to promote protective motor activity and healing behaviors, sometimes this enhanced excitability state persists long after the peripheral tissues have healed, and dominant sources of pain shift to the CNS. Presentation of this mechanism overlaps with signs and symptoms of nociceptive and peripheral pain, making it difficult to identify. Upon evaluation, they have excessive sensitivity to inputs that are not normally pain-provoking, but the tissues appear healthy even with diagnostic imaging. Ligament, muscle, instability, and neural tension tests may all cause pain, and nothing may seem to ease their pain. Prolonged and maladaptive central sensitization is a dangerous state for patients. Clinicians can start to have doubt about the validity of the patient's experience that is only compounded with the lack of test or imaging that can identify this mechanism. Unnecessary surgery, injection, and forceful manipulation are offered up to patients with lack of positive outcomes. New research has shown that PT-delivered cognitive behavioral therapy has proven to help patients understand how their psychological, social, and environmental factors influence their pain, function, and quality of life, which leads us into this next mechanism. The effective mechanism of pain is seen as pain arising purely as a result of emotional turmoil. The way we think and feel has vast repercussions on the brain processing that orchestrates the sensations we perceive as well as on the health vitality of the body's physiology. Although debated heavily, the safe stance is to accept that emotion or affect is a dimension of the pain experience. Going back to the pain definition from the IASP, clinicians should consider the importance of inputs like loneliness, hopelessness, sadness, fear, anger, and frustration that can be caused by a pain state and only drive it further. If patients have increased negative affect, pain catastrophizing, fear of pain, or pain anxiety, their potential for avoidance and escape behaviors can lead to chronic musculoskeletal pain syndromes. It may be possible that pain states become ingrained in unique CNS pathways like those of memory. And like memories, we seem to be able to hold them in our subconscious filing cabinets, only brought out when specific cues are called. Chronic pain patients can be taught to focus less on their pain and more on recovery through cognitive behavioral training and coping techniques once they have a better understanding of the pain mechanism involved. If clinicians can favorably alter the way patients think and feel about their pain, we can greatly enhance the rehabilitative process of functional restoration without reliance on a number for pain improvement. The autonomic/motor pain mechanism is a component of pain controlled by the autonomic nervous system. The sympathetic nervous system is involved in all injuries and pain states. Sympathetic autonomic responses to noxious stimuli result from nociceptive rather than perceptual processes. This can be caused by many things, but trauma tends to be the most common. SMP, or sympathetically maintained pain, can refer to complex regional pain syndrome, post-traumatic neuralgia, and phantom limb pain. The SNS is believed to be the blame for pain states due to the successful alleviation of symptoms following sympathetic nerve block techniques. However, many patients do not respond to sympathetic block techniques, and ongoing pain states have multiple mechanisms, and all aspects of ongoing pain need to be considered. Also, research suggests that when a disorder has a component of sympathetically modified pain, it is not at the fault of an abnormal sympathetic system, but there is abnormal sensitivity to normal sympathetic secretions in injured nerves and peripheral nociceptor terminals. With the motor system, injured muscle acting as a site of nociceptive pain causes ongoing tension in muscles that can provide a provocative environment for further enhancing symptoms, triggering the pain and starting the cycle all over again. The pathobiologic mechanisms driving pain alter and shift with time. For example, a patient who has acute shoulder pain with no significant damage or abnormalities likely has the primary pain mechanism as nociceptive, with pain driven from the periphery. If the same patient returns 9 months later with the same pain, the structures in the shoulder are likely to have healed. The pathobiology is unlikely to still be nociceptive, but deeper in the circuitry and processing of the CNS. Ongoing pain states are often of great concern to patients, especially if their pain has not been validated or successfully managed. They will likely have maladaptive thoughts and feelings about their pain that further add to it. The cognitive and emotional aspects of pain generally get more involved the longer a problem persists. There is no device or one test that allows a clinician to instantly know which pain mechanism is dominant. This requires careful history taking and synthesization of their pattern and behavior. Despite the advancement of pain science, many clinicians continue to seek a diagnosis of a tissue problem and fear missing a pathology, leading to inappropriate use of imaging. Evidence suggests that clinicians who endorse biomedical pain beliefs are more likely to engage in care that is opposing to guideline recommendations on advice to rest, protect the body, taking time off work, and referral to expensive surgical interventions. So, what do we have to use to assess pain? A pain scale is a chart that represents different levels of pain that clinicians give patients to help them describe how much pain they are feeling. Unidimensional pain scales are quick and easy to use, and they provide rapid feedback about the effectiveness of interventions and track pain progress over time. However, they are a subjective assessment with variability. The scores are gauged by experience and can be altered with ongoing patient experiences. There are many pain scales, but the most often used are the Numeric Pain Rating Scale, the Visual Analog Scale, FACES Pain Scale, and the Verbal Rating Scale. These being unidimensional means patients can use words, images, or numbers to describe their pain. The tests essentially attempt to get an objective measure of a subjective experience. These scales are fairly easy to use but not precise. With a unidimensional scale, patients must weigh their multidimensional pain into a single score and not accurately convey information about the patient's specific pain. Patients tend to differ in the dimension of pain they find the most salient, meaning one patient's score of 7 out of 10 may reflect their sensation of pain, while another could reflect their emotional state. In terms of treatment, the first patient would benefit more from an analgesic alone, while the second may benefit from anti-anxiety medication, cognitive behavioral therapy, or counseling, with a decrease in the analgesic medication. In order to address the multidimensional aspects of pain, we would want to use a multidimensional measurement, right? Well, let's go ahead and go through a couple together. The McGill Pain Questionnaire, in its short form, consists of subgroups of words describing sensory, affective, evaluative, and miscellaneous components of pain. The patient's total score or pain rating index is a sum of the ranked scores. The MPQ has been found to be highly reliable and valid in both patients with acute and chronic nociceptive pain. Neuropathic pain is more difficult to pull out, and discriminative tools to aid in the diagnosis of neuropathic pain should not replace clinical examination and reasoning. Tools like the McGill Pain Questionnaire have some discriminative properties but lack specific scales with neuropathic descriptors. The Lands Pain Scale, DN4, Pain Detect, and Neuropathic Pain Score have been used as screening tools for neuropathic pain in which to differentiate between neuropathic and mechanical pain. The effect of mood and affect on pain is often screened through anxiety and depression measurements, such as the Hospital Anxiety Depression Scale, Patient Health Questionnaire, or Generalized Anxiety Disorder 7. Also, negative pain beliefs and coping styles can be assessed. Pain catastrophizing is a negative emotional, cognitive, attitudinal pain perception that leads to overprediction of pain, increased use of healthcare, and longer hospital stays. The pain catastrophizing scale has the patient indicate the degree of frequency of thoughts or feelings associated with pain. Higher scores are associated with poorer function and development of chronicity. Additionally, a patient's pain beliefs are central to their reporting of their pain and are informed by their understanding of their pain mechanism and the interaction of pain on their function and mood. Self-efficacy is consistently associated with impairment and disability, distress, and pain severity. The Pain Self-Efficacy Questionnaire assesses patient confidence in performing activities of daily living and can predict good response to self-management and return to work. Pain-related functional assessment is used to measure disability and pain interference with daily activity through multiple domains of function like activity, work, socialization, mood, and sleep. The Pain Disability Index consists of 7 domains, including family, home, responsibilities, recreation, social activity, occupation, sexual behavior, self-care, and life support activity. The existence of so many measurement scales used in clinical practice makes the evaluation between dimensions very difficult. Even with knowledge about pain science, it is easier to assess pain as a unidimensional number, and treatment follows suit with only mechanical interventions. PTs can be overwhelmed by trying to assess pain with minimal time, resources, and training, especially in a busy clinical setting. It is recommended to use short screening tools to specifically highlight when cognitive, psychosocial, and social aspects are present. To help out, the Initiative on Methods, Measurement, and Pain Assessment in Clinical Trials recommended 6 core outcome domains. Pain intensity assessed by Numeric Pain Rating Scale, physical functioning assessed by the Multidimensional Pain Inventory, or the BPI, emotional functioning assessed by the Beck's Depression Inventory, and the Profile of Mood States. Patient ratings of improvement and satisfaction with treatment assessed by the 7-point Patient Global Impression of Change scale. Their aim with this is to achieve consensus as to what domains to measure and which tools to use to improve clinical trial methodology. Although using a more comprehensive questionnaire or tool, or even multiple of them, will take more time than a unidimensional measure, a multidimensional approach can help the interprofessional team establish realistic goals that align with the patient's needs. Outside of outcome measures, improving our ability to have a pain conversation is key. The American Pain Society suggests 7 further elements to aid in pain assessment through subjective questioning, looking at onset and pattern, location, quality of pain, aggravating and relieving factors, previous treatment, affect, and barriers to pain assessment. These aspects any clinician can include into their subjective exam and even throughout the evaluation to aid in assessment while not needing to perform a specific outcome measure. Just being willing to discuss and acknowledge a patient's pain can have a positive impact on the patient and the patient-client relationship. The World Health Organization created an international classification of functioning, disability, and health, known as the ICF model, that focuses on human functioning and provides a framework that captures how people with health conditions function in their daily life. It provides a scientific basis for understanding and studying health and health-related states and can assist with matching patients to interventions. It has a biopsychosocial framework that provides an overall view of health through biological, individual, and social lenses. Toussaint Laflamme and colleagues created a model of drivers of pain and disability to reflect a biopsychosocial approach with using the ICF. They included 5 domains falling under 2 categories. 1, more common and or modifiable elements, and 2, elements that are more complex, less modifiable, and will prompt more aggressive or outside care to address the problematic domain. The domains are nociceptive pain, nervous system dysfunction, comorbidity drivers, cognitive emotional drivers, and contextual drivers. Although these pain domains can interact and their relative individual contribution to pain and disability can modulate through time, the model gives a structure upon which the clinician can base their assessment and treatment interventions. Once a patient is deemed safe for rehabilitation, clinicians should establish the patient's profile based on the presence or absence of elements within each domain, which then you can identify and target where relative treatment efforts should be focused. All of this information goes back to the title of this presentation, that pain is not a number. No one pain pattern will be the same, and no 2 people will react and think the same way about their pain. The science behind pain still continues to be researched due to its multifaceted nature and subjectivity. A clinician must acknowledge that a patient's pain and the resultant emotions and thoughts about it are unique. It is important to make decisions based on information in all of the domains of a patient, rather than see pain as a number to check a box and move on. In order to do right by our patients with pain, clinicians must have the ability to categorize pain and make clinical decisions related to the category. This does not need to look like completing 5 outcome measures each time a patient reports pain, but starts with an acknowledgement and attempt to look deeper at pain in their patients in the best way they can. It can be as simple as asking a few more questions in the subjective interview, but can be more in depth through the use of detailed and tailored outcome measures. To take on pain in this new way may mean admitting that previously comfortable practices may have been wrong, or that our patients' responses to well-meaning interventions may have occurred for completely different reasons than previously held by the clinician. Although it may be difficult and a slow transition, the integration of pain science into clinical practice is essential to set ourselves up for the best treatment and care for our patients, as well as set our patients up for the best recovery of function and continued success outside of PT and after our plan of care.